All right. Well, good morning, everyone. Welcome to EMS by the Numbers, Impact of COVID-19. We're going to do this as a NEMSIS public training today. Today is July 7th, 2020. We appreciate you being here with us this morning and are excited to see this presentation from Clay Mann. I think we've got a little bit of echo. So if you're willing to check your microphones, there we go. I think we got it. But feel free to be ready to unmute your microphone if you have a question or a comment. Also, you're welcome to use the chat feature and we'll watch those. There will be some time at the end of today's presentation for some questions regarding the information Clay is going to share with us today. I think we're ready to jump in. Clay, are you ready?
I am, thank you. Can you hear me okay?
Yep, you sound great.
Good, good. I apologize for the silhouette today. Just a lot of sun coming in through the windows, and I will work on that. I apologize. But we have a lot of great things to talk about today. I'm truly excited to be able to share this information with you today, mostly because we have just had so few opportunities in regards to EMS and NEMSIS, where truly the entire country is focused on surveillance and quick turnaround of data to inform decisions at national and local levels, and how incredibly important it has been to have NEMSIS data available to do that. So I'm incredibly excited to talk about this and to tell you a story. So I'm going to do a little bit of background about NEMSIS, just because we may have folks on the line who just aren't completely familiar with NEMSIS. I'm going to focus on the incredible value of surveillance type data that's coming out of NEMSIS, and we have some great folks on the line, Todd with First Watch and others that do great work with surveillance of EMS data. So clearly we've got a very expert group of people here with us today. I look forward to the conversations. To describe that, we'll talk about data flow, right? Data structure and data flow, and then how we have been able to work with the Federal Healthcare Resilience Task Force to really develop trends in pre-hospital care that are fairly timely. So what we need to do with NEMSIS data is we need to tell a story. I'm gonna tell you a story today. It's gonna be my story. What I mean by that is it's my interpretation of the data. Others may clearly interpret it differently, and that will be informative until we can have kind of the objective analysis of the data that allows us to make sure that we're interpreting correctly. But we have to get used to sharing stories with this data because it is so rich and it is such a large data set. It's time to start doing that. So let's take a step back. I apologize, I'm getting on my soapbox again. Let's begin with just a brief overview of NEMSIS, the National EMS Information System. Really, it's a way for the entire country to come to a universal understanding about how they're going to document patient care. When you call 911 and you have emergency services come to your house and they document the patient care that they provide, that's been standardized across the entire country using NEMSIS with the data dictionary. And then we check software. So you can see this gentleman here, has a laptop there. He's working up this patient, collecting data. We test all that software for compliance to the NEMSIS standard so that it's all implemented in the same way. And then what's important is these last two bullets, right? Then we facilitate the exchange of data, the interoperability of data. So there is this, you can kind of think of it as a closed health information exchange, where data flows fairly seamlessly. We'll talk about this fairly seamlessly from the living room of anywhere USA, where a paramedic or an EMT is caring for a patient, to the National EMS database that's listed here as the last bullet. And that's the data that we're going to be looking at today. So just real briefly, this is just a quick slide. NEMSIS v3 is the current data set we're using. Think of it as a great big palette, this big purple pie. has lots of elements to choose from. A local EMS agency can choose the elements that they want to collect. A state will mandate that every local EMS agency collect elements that they want to aggregate at the state. And then we instruct every state to include in their state data set 200 or 165 national elements that we want to come all the way up to the national registry. So that's kind of how the database is constructed. How the data flows is, here are the patient care reports from 3 different agencies, agency A, B, and C. Medical device data, 911 call information can come into that patient care report. Once they finish it, it moves via web services. It's an electronic machine-to-machine talking into a state database. And as I mentioned, that state database will have the national elements in it, and that comes up to the national database. Now, the mechanisms, the technology in place here is pretty incredible. It works very, very well. If we do a tabletop experiment where we have, I don't know, a paramedic or an EMT in a living room in Fargo, North Dakota, and they complete a record, and we're kind of on the phone with them, you know, and they complete a record and press send on their laptop. By the time that record goes to the state repository in North Dakota, and then the North Dakota repository sends it to the national database, that subset of 165 elements is about on average 7 minutes. Well, we would love to say that we have a data set that is descriptive and characterize EMS care 7 minutes ago across the entire US. That would be fantastic. But there are reasons why EMS holds on to records. Maybe they picked up a patient that's unconscious, and so there's lots of elements about patient demographics, past history that they can't collect at the beginning, so they wait till the patient's in the emergency department, or they call the hospital back to complete the record before they send it in. There's a myriad of reasons why data isn't coming in at 7 minutes. Some of them are fixable, others are probably not, but we can certainly try to be more timely with our data collection, but we've made incredible strides, and we'll talk about that in just a minute. Who participates currently in sending data from the living rooms across the United States or the side of roads to the national database? It's the states here that are in green. 47 states and territories are submitting, I don't know, 30+ million records per year from over 10,000 agencies. So I took this snapshot from the NEMSIS Public Research Cube. This is available on the website. It's a way to search through lots of data. Just did a quick snapshot of data by years. And this data cube is up to date as of a week ago. So we keep this data for you to utilize for research purposes very timely. But you can see that just for the version 3 data that we're talking about, we now have a repository available to you to tell a story in EMS of 92 million EMS activations. And you can see for 2009, we collected almost 36 million. For 2020, we're already at about 18.5 million records. So clearly, we may be closing NEMSIS for 2020 with close to 40 million records. So we're incredibly excited about that. But that's the power of kind of timely data, right? So anybody on this call who's worked in healthcare research at all knows, and I don't think it's a far-fetched statement to make, that if you're working with a state registry or a federal registry of healthcare events, that the data set you're going to get is going to be 2 years old, right? Just hospital admissions, ED admissions, those traditional administrative type data sets are so dated to almost be impossible to use, particularly for something like COVID that we've been talking about. So what I want to emphasize is that NEMSIS has been incredibly valuable for a number of reasons. Today, we're going to talk about why it's incredibly valuable, because it's a surveillance tool. And if we continue to just grease the process a little bit better through policy and through just education to our providers, it can be a near up-to-date national look at what's going on across the country. Let's talk about this story of COVID-19 that struck the country as an epidemic early in 2020. So here I just want to make a quick point that so this is a snapshot of data that we received last week that just shows you how many records that we are receiving per day at the National Registry. Up here in the green, the red is failed records, and we work to correct those issues. But what I want to draw your eye to is down here, this idea of submission lag. So what this is telling you is, what is the percentage of records the National Registry has for any given day, a certain number of hours after that day, right? So what we're kind of saying here is, for example, we have 25% of the records that happened on any day within about 26 hours. So within about one day, we have all the records from the entire country that occurred that day, the next day. And so if you continue to read down through this, right? So we have about 50% of all the data across the country in about 3 days. We have 75% of all the data on any given day within about 8 days or 186 hours. So you can see that it's actually very, very timely. We have 75% of all the records that occurred last week are already here, right? And then we have those laggards that are coming in to get to that 90 or 95%, but it's actually very, very timely, right? This is incredibly valuable for looking at COVID. So let's build a story, right? So let's use this NEMSIS data. Let's identify, we of course can't identify COVID-19 in the pre-hospital environment. They need to be tested so far in a hospital setting once they call 911. So we don't often know whether a patient who's demonstrating ILI or influenza-like illness symptoms, whether it's truly COVID or not. But we have those records. They're going in, they're seeing patients with influenza-like illness symptoms. We can use the NEMSIS data, primary and secondary impression, which is populated by ICD-10 codes. Here's some code sets that we use to identify EMS calls that included a patient with ILI. It can be B79 codes, influenza codes, pneumonia codes. And then of course there's symptoms that are associated with ILI: cough, shortness of breath, fever, pharyngitis, all of the things that the CDC has come out and said is associated with COVID, or we know has been associated with influenza in the past. So let's build a sample of patients that meet these criteria. And I can talk to you in more detail about those criteria if you're interested. But let's take that sample and now let's build a research methodology to look at what's happened this year for ILI patients. So let's build 2 reference years and then a study year. So let's have 3 time periods that go from the 40th week of a year to the 25th week of the next year. So that's going to be like mid-June, right? The 3rd week in June. And then compare numbers and rates over those 3 time periods. So our time period 1 is the 40th week of 2017 to the 25th week of 2018. Period 2, the same thing, 40th week of 2018 to the 25th week of 2019. And then our period of interest, our time series of interest, is the 40th week of 2019 through the 20th week of 2020, right? So just like 3 weeks ago. And we're doing it 3 weeks ago, right? Because we're wanting to ensure that we have all the data for that time period. So you can see the numbers that are associated, how many records we have for each of these time periods. So this is a great sample. It's a large sample. It's generalizable. There's 42 million EMS activations here for us to look at for ILI symptoms. So clearly this is you can consider this representative of the country. So let's graph those, and let's talk about these graphs. So this is counts. This is counts of EMS activations with patient contact. And then we'll add in ILI patients in just a minute. But let's just look and see whether or not there's been like a real change in the number of EMS activations in our test time period compared to other years. So if we just look at the count of 911 initiated EMS activations with patient contact for the 3 years, the blue 2007 to 2018, the green 18 to 19, and then our test of 19 to 20 in red. Things to keep in mind here and why these are staggered is because each of those years, more states submitted to NEMSIS. So for the 17 to 18, there were 32 states. The 18 and 19, there were 40 states. And then the 19 to 20, our test, there is 47 states and territories. Or excuse me, 44, let's just do states, 44 states. So that's why the count goes up with each year. Then there's also this incredibly steep slope at the beginning of each year. If you look at the x-axis, that's the weeks we talked about. 40th week of the last year to the 25th week of the next year. You can see on week 1, wow, just there's a surge. That's because when states come on to NEMSIS, they traditionally come on at the beginning of a calendar year. But if you track across there, you can clearly see at about week 10, end of February, beginning of March, there was a drastic reduction in the count of EMS activations in this country with patient contact. That number dramatically dropped, right? You can see this big drop. Well, to look at ILI, let's use this as our denominator. So EMS activations with patient contact, 911 EMS activations with patient contact, and call that our denominator to look at rates of ILI patients. How many ILI patients over all EMS activations with patient contact? What is that percentage? What is that rate? So let's compare the years. So here first is the count of ILI activations. So this is just the raw count. You can see in the y-axis, it's in thousands. You can see there's always a peak in ILI type symptoms, influenza-like symptoms associated with the traditional flu season. You can see that in both of the prior comparison years. And then you can see what really happened starting in week 10 of this year and associated with the COVID-19 outbreak. Just the number really increased. This is hard to look at. It's hard to interpret because each year has a different number of records, right? So let's do what we talked about and turn it into a rate. So now this is the percent of 911 activations that had patient contact where the patient demonstrated ILI symptoms, right? So influenza-like illness symptoms. So you can see we've really standardized it. So you can see like the end of a year, the 40th week, you know, through beginning into flu season, they're very similar because now it's just a rate among all EMS calls with patient contact. What is the rate? And the rate had been very constant. You can see we had a bad flu-like year, 2017 to 2018. That's been well documented. And then you can see how it traditionally drops off, but how for us in the United States for week 10, associated with COVID-19, that rate of ILI activations that our providers were responding to just dramatically increased. Now you're right, you're looking at a difference between 5% and 8%, but remember, there's 43 million activations in this graph, so a percentage increase is a lot of volume, a lot of volume. So let's put some markers on this to tell a story. So we talked about that week 10. So when is week 10? Week 10 was the end of February, beginning of March. To put it in perspective, this is where the week in which the first cases of community spread were reported. So people began to feel like their neighbor could have it rather than people traveling from overseas. It was the week that the FDA began to open up testing, but there were problems with the tests. And Vice President Pence was put in charge of a task force. So clearly the public knew there was community spread week 10. Week 12 that I've marked here, this is kind of mid-March. March 13th of this week, President Trump declared this a national public health emergency. On March 16th, the same week, 12, he started the 15 days of slow the spread, and most states began to have shelter in place rules or requests go into place. And through about week 19, when states started to reopen up. So I'm gonna put these two visualizations on every graph so that we can kind of watch and see what happens. So you can clearly see something happened at week 10 once the public recognized that community spread was happening. There was either much more influenza-like symptoms and COVID, or people were concerned and were calling 911 more often. You can see that really within 2 weeks of the closure, there was a dramatic reduction in the number of ILI activations. And we can see maybe there's a slight turn upwards again. The slope is turning upwards again with week 25. And that of course will remain to be seen if that truly spikes again. Well, let's put all this into perspective with some of the press that was going on at the time. I remember this was a very confusing time, and trying to understand what was happening across the country, particularly related to COVID, was difficult. So here's a popular article we saw in April, the beginning of April, that there was this idea that cardiac arrests were just skyrocketing with coronavirus. Well, let's take a look at cardiac arrest activations in the national data set. Here again is counts of cardiac arrest, either before or after EMS arrived. We can see the distribution we expect for counts. We can see the jump at the beginning of the year. We can see a slight increase beginning in about week 12, I guess, and then tapering off, still not back to where the other, the counts are perhaps even lower now than you might have expected. Let's turn it to rates. Okay, here again is the rates. We see really just kind of variation, kind of around the mean as we're kind of going along until that week 11. And then you can see that cardiac arrests really did, the percentage of calls really did dramatically jump. With that same kind of a decrease happening like 3 weeks into the shutdown, but clearly still trying to trend down, but not returning to the baseline that we would expect to see. Well, there's been lots of thinking about why that remains to be true. There clearly was reports of people dying at home rather than at the hospital. And there was this idea perhaps that patients were so worried about what they were seeing on TV as they show snapshots of ICUs and EDs just packed with people with coronavirus. Maybe they just weren't going into the hospital, right? They didn't dare or trust, or they feared seeking healthcare. Let's take a look at that as an idea. So maybe a way to capture that is look at the number of scene deaths that were happening across the country during these 3 time periods. So again, here's the counts. We see the type of lines we expect to see with a jump. It's kind of associated with COVID. If we turn this into rates, we can see the rate is pretty standard for EMS attended scene deaths at a little over 1%, with a real jump beginning again when we expected to see it. And again, not yet back down to baseline for the last 2 comparison years. So it's beginning to tell us the story, right? So let's look at something. Okay, so cardiac arrests went up, the rate gone up, scene deaths went up. Let's look at something that we might anticipate went down. So injury-related activations. So less people are driving, they're sheltering at home, they're not out recreating outside. Perhaps injury activations should have gone down. Here's our numbers. You can see the drop that occurred in the time period of interest for counts. Let's standardize it at a rate and see kind of what's happening. So here's the standardization of the rate. You can see the rate is commonly high coming out of the summer months, drops down for the winter months, and then begins to trend back up through the spring as we're getting into summer. But this dramatic drop in EMS calls associated with the COVID information that was made available to the public and the close down of states, and how the number, once we closed down, perhaps, I don't know, this is my story, once people began to get past the fear factor and maybe were sequestered, just going crazy, they began to venture out again, and you can see the rate has now returned to what we expected to see, equal to the comparison years. Vehicle crash activations should be the same story, right? So again, here's the numbers, here's the count of EMS activations with a vehicular crash. We see the drop. If we standardize that, then we see this drop during that time period of interest again, with it slowly coming back up, and now about what we expected to see based on comparison years. Let's look at some of the other things that have kind of been in the popular press related to the COVID epidemic and some of the other things that people are worried about. Let's look at opioid related activations. So here's the counts of cases where the provider indicated as a primary or secondary impression that there was an opioid related to this call, right? So you can see the numbers by year. Let's again standardize it. And interestingly, we see that rate is just continuing to go up, right? Almost as if COVID was a trigger, and it's just, it's a pretty substantial slope, not returning to baseline. So this is an important story to be told, and clearly important research could happen here. Let's look at it just from a slightly different perspective. What if we just looked at the counts where naloxone was given, where Narcan was given? So again, we're kind of looking at we're trying to look at the same thing just through a different lens. Here's the numbers that we're seeing for the 3 years. Let's standardize it in a rate. And again, we see that it's like a trigger's been thrown, right? It's just not, it has just gone up and has not returned to baseline as of yet, right? So an important public health problem that we need to look at. Let's look at some other things that have been talked about. How about count of suicide related activations? So here's the numbers. Trends again that we expect to see, there has been a drop off. If you look at the rate, really hard to distinguish anything really happening here. But of course, remember, those familiar with EMS data, calling a activation truly suicide or abuse or some other reason for the injury like that can be difficult for EMS to do, and policies regarding that changes from state to state. So this one is probably hard to interpret. Let's go to alcohol related activations. So again, here's the counts. We see a drop. If we standardize that, then we do. Different from opioids, I mean, another drug that is taken for similar effect has kind of gone back up to baseline, right? So maybe this idea of social drinking not being available during the shutdown is why we saw the decrease. And now as states are opening back up, the numbers are rising. How about mental or behavioral related activations? So this includes primary impressions of anxiety, of altered mental status, of major depression, of mental disorder, of signs and symptoms involving an emotional state, emotional shock and stress, strange or explicit behavior. All of those ICD-10 codes are in these counts. Here's the counts. If we standardize that rate, then again, we see that same pattern, but pretty much a return to baseline. We'll have to see if it actually returns to baseline. But once people are coming out of that sheltering in place, those numbers of calls have dropped. So I moved through that very, very quickly. I wanted to make sure we had time for questions. We can go back to any slide you want to go through. But again, I'm just going to emphasize the 2 points that I'd hope to make. One is you've just been able to see what's happened across the country as of 3 weeks ago, right? For all EMS, for 42 million EMS activations in that comparison, 22 million for this year. It really provides you with a snapshot of truly where we probably are. And second is it's a story. There are so many stories here that we need as EMS providers, as vendors, as software companies, as state representatives and researchers. We need to tease out these stories and make sure that the public and those who fund us at the federal level recognize the type of data and information that can come from the pre-hospital setting. So I'll stop there and would love to entertain questions. Any questions about the methods we used?
Hi, Clay. It's Mike Taylor.
Hey, Mike. Hey, Mike. Nice to see you.
Hey, you too. I see you're still in witness protection.
Yeah. Sorry about that. It's so bright back there. I apologize.
Yeah. No, it's all right. The motor vehicle crashes went down. Did you do any look to see if the severity of the motor vehicle crashes went up? I left New York and now I'm in Florida. Doing trauma stuff. One of the things that we have been told from the traffic folks is that yeah, there's definitely been a decrease in vehicles on the road, but they're now traveling, no joke, at 100+ miles per hour, because down here it's like 4-lane freeways, and when there's nobody on it, it's a raceway. So I was just curious if, along with the rate of vehicle crashes going down, have you looked at the other data elements, the other data points, to see if the severity of the crashes have gone up? You know, extrication times, injury patterns, that stuff.
Yeah, that's a great question, Michael. No, we haven't looked at that. That would be a great story to investigate. And I'll mention, for those that are truly interested in vehicle crashes, you know, for FARS and many of the databases that NHTSA relies on, they rely on a CABCO for injury severity, which is measured by police when they're on scene. NEMSIS version 3 allows you to calculate what's called a revised trauma score. So directly to Michael's question, we could look at a revised trauma score, which includes systolic blood pressure, respiratory rate, and GCS as a measure of injury severity, physiological injury. To look at that, right? So that's a great question, Michael. And you're right, we could look at extrication. Was it necessary in the delay elements? See whether they're becoming more complicated crashes, and whether injury severity of those patients suffering those crashes is higher. That would be a great study, Michael. We haven't. That'd be a great study.
The other one, I got distracted when you were on that slide about the cardiac arrests.
Mm-hmm.
Yeah. Word on the street, and I guess there is some truth to this, is that folks are waiting longer. They're afraid to go to the hospital. They're afraid to go to the emergency department. So they develop symptoms at home and they wait longer before calling 911. And then when they do call 911 to go to the ER, they are now sicker than what they should be or what they normally would be. I didn't know if you had thought about looking at any of that to see how you know, the numbers of people the number of people calling 911 has dropped, but how sick are they now as opposed to what they typically would be?
Yeah. That's a great. That's another great question that we've had a little bit harder time thinking about, right? So that could be captured, just like you said, in cardiac arrest. before or after EMS arrived. We also tried to kind of capture that. How often are they coming across people who are dead on scene, right? Maybe this speaks to them waiting longer, but this idea of them being sicker, right? We have vital signs, right? So maybe we could look for certain impressions, stroke,
time from symptom onset.
Yep. That would be a great one to collect. Yep. To actually look at and see if that time the symptoms began as longer until EMS arrives. Yeah, Michael, that's a great one. No, we haven't looked at that either. Lots of researchers on this call will be on the phone to you right after we end. I'm just sure.
Well, I don't deal with the NEMSIS data set anymore, but I was, and I'm not up to speed on 3.5, but.
Yeah, great. You know the variables well enough to know that those.
I'll always give anybody my opinion, but there's no guarantee that I'm right or wrong.
All right, great. Yeah, great comments.
Just I do want to say thank you for doing this, Clay. This was excellent. Thank you for doing this.
Well, you're welcome. You're welcome.
Hey Clay.
Hey Clay. So go ahead.
Hey Peter, how are you?
I'm good, Clay. Good morning. Excellent report. I was really excited to see this. Would you be, I can talk to you offline, willing to present this in a shorter format on Thursday to our statewide EMS group that we have a call every 2 weeks?
Oh, sure. You bet. And then I'll also mention, I'm sorry.
Go ahead.
I was just going to also mention, Peter, thank you for calling in. So Peter, Dr. Talek is the EMS medical director for the state of Utah. So thanks for the question, Peter. I was going to mention that we're actually going to, we're building a Tableau report that mimics these exact visualizations at the state level, right? So Peter, you at the state level will be able to look at, for example, scene deaths for the 2 comparison years compared to what's happening this year and track it over weeks, right? We'll update it on a weekly basis. So at the state level, you'll have a similar way to look at this.
Excellent.
Yeah, and I'd be happy.
Thank you, Clay.
Yeah.
I'll talk to you offline. Appreciate it. Great report.
Thank you. Hey, Todd, I think you had a question.
Yeah, just actually great job. Couple of quick thoughts. One of the things we're doing to address the difference in number of participating agencies that might help, because I think the story will be the same, but I think the rates are probably exaggerated by the reduction in volume in those other areas. So one of the things that we're doing is looking at it the way you have, which I think is great and makes a lot of sense. We're also being able to only select those sources where we have data for all in your case, all 3 periods. And that way you would have you'd have a smaller sample, but it would be more apples to apples from 2018, 2019, and 2020. And that I think would give another perspective that you might find interesting. And then I thought I would just point out, for purposes of thinking about it, and maybe something to do later, our information aligns really well with what you're showing, with the exception of the opioid and the overdoses. And we actually show a similar reduction as to the other areas. And it would be interesting to explore that further if you just made me pull something out of my rear about it. My speculation would be that most of the first watch agencies, because they're contracted at the agency level, tend to be mid to large size or metropolitan areas. And it would be interesting in your data to see if you could slice that out by region or metro versus more suburban, rural, as you go through it. And I wonder if there was actually a difference, or if perhaps the places that were less COVID affected saw less of a decrease in, or even an increase, as you showed with the opioid and overdoses, as you go through it, because everything else lined up, and I was just nodding my head the whole way through. Yep, and I saw that, and that made me question. So it's really interesting.
Oh, fantastic, Todd. So let me, great comment. So let me respond to your first one. Great idea for a denominator. So your metric to build that denominator is, say, for example, agencies that submitted at least one record for every month during the 3 years or something like that. How are you ensuring that, like, you feel like you've got complete records for that subset of agencies? What are you using as kind of your cutoff for that? Does that make sense?
So it's a great thing. In our case, one of the disadvantages is we have to look at the data from each agency and address it distinctly for each agency. One of the advantages that comes up is once somebody comes on board with us, we have all their data from that point forward. So, we're literally seeing every, CAD record, ProQA record, EPCR record that's submitted. And so, even though there may be a reduction, they're also watching for, for billing purposes, as well as documentation that those EPCR records get in. And so I speculate that because we're getting that data directly, it may not be subject to the, quite the potential for, lag or disruption as it works its way, through the process to the state and then to NEMSIS. So in our case, we just simply say, was this agency live with us during those 3 periods of time? And then sometimes the only issue we have to address is if they changed, data sources, they changed CAD systems, or they changed electronic patient care record systems, so that we make sure we're looking at apples to apples.
Okay.
As we go through it, because a lot of our, like COVID, we did hundreds of COVID, what we call triggers. 72% of them were customized for how each agency was documenting COVID in their agency, and it was often just in the narrative. And so, getting that COVID information, was harder to get to, but then once you have it, you get not only the generic ways of doing it, but when they actually identified it as a, COVID, or even in many cases, COVID negative, and so you can pull those out. So it's more work, but in that way, it's just they're on board or not. And so anybody who's new, we'll typically pull a year's worth of data, but if we're looking 3 years back, we can't use them.
Got it. So just the live date. Got it. And then your second comment about the opioid rate. Yeah, we'll look at that by urbanicity or by geography. I think that's a great question. It's a great question. It would be interesting if what you found, and maybe we can talk offline, Todd, if we do that, if we find some differences, we'll talk to you, because it would be interesting if there truly is a rural, versus a very urban effect. Yeah, great.
Yeah. And I think a super interesting, you were talking about research thing with this COVID stuff, and in our world, it's like EMS in general, where, some places are dramatically affected, some places are not affected at all, some places are just ramping up and not. And, I think if there's ever, for research people out there, if there's ever a spot to look at, kind of like both the demographics and the geography, it'd just be super interesting to watch, these things that come and go, because, for a while it was New York City, then it was New York City and New Orleans, and now they're calming down, and Houston and other areas are picking back up. And I think that's what we're going to see. And that's where it's almost like you've got to show your charts, and then like maybe at least regions or something, because California is very different than, Montana.
Yeah, exactly.
Super interesting stuff. Really nice work.
Oh, thank you. Yeah, thanks, Todd. Yeah. Great comments. Yeah, thank you. Lots of expertise on this call.
So Clay, you have a couple of questions in the chat, so I can read them to you. The first one is from Karen Card, and she says, I'm interested in how we could quantify how many people started calling EMS for ILI instead of considering self-transport to the hospital.
Oh, interesting, interesting. So state that just one more time. Let me reframe it.
She says, I'm interested in how we could quantify how many people started calling EMS for ILI instead of considering self-transport to the hospital.
Yeah, I wonder how we could capture that. That's a great idea. There's clearly ED data sets, but as we talked about, that it's really hard to get timely data. I know that some of the sources, I know HHS has required there be new reporting out of emergency departments and hospitals. Maybe we can look and see if there's some way to correlate the two. That would be a very interesting idea as well.
Mr. Mann, Dr. Mann, I'm online now and I'd like to comment.
Yeah, please.
So I only noticed that we were graphing these counts as if we were certain they were new incidents that wouldn't have been present in past years. But I know from experience with my family members that I told them, if you feel like you've got COVID, you do not call me. I can't take you to the hospital. You got to call EMS. And I bet that was going on all around the country. And I don't doubt that there's more. I just think that there's two simultaneous things going on. And you are right. That was my first thought, is we should take this sample and match it to ED data and kind of get an idea of how often that happened. But anyway, I'm intrigued by many things that you said. So that's all I wanted to point out. Thank you.
Yeah, thanks, Corinne. It's a really good idea. Yeah, I hadn't thought through that, but you're right. As a concerned family member with elderly, for example, family members far away, yeah, you'd be telling them, don't talk to your neighbor, call EMS for the ride. Yeah, that's a really good thought.
Yeah, I think what's going to be so interesting, it's Toddy, and what's going to be so interesting about that is that every flu season is so different that way anyway. Like H1N1, we thought was just going to kick EMS butt, but because of the age banding, I think, most of our EMS agencies were not as busy as other flu seasons. And then Karen, really, really good point about it in terms of, now you've got that other effect of people, who don't have someone else to call, the little old people that just don't want the sirens because their neighbors are going to know. I mean, it's a lot of stuff to figure out as we go forward, that's for sure.
Yeah, exactly. Yep. Yeah, thank you, Karen. Really good thought. Other comments?
Yeah, there's one other question from Benny from EPR Systems asking, do you prefer getting data fast or getting the data accurate?
That's a great question. I can see for those who have their screens on, everybody's smiling. Yeah, that's a great question, right? And there's been states that have struggled with that, and we have business rules associated with NEMSIS, and you can make them warnings or you can make them fatal errors and require EMS correct the error. So like if you report a pregnant male, and some states turn everything to warnings because they just want to maximize their data. And then when they look at it, they see that actually there are a fair number of pregnant males that are in there that would have been caught if there was a steep enough penalty associated with not having correct data. So yeah, we walk a thin line, right? I think this having like 80% of the data on any given day within 2 weeks is astounding, right? And there's probably really good reasons why people wait. And a lot of it is related to data quality. So do I expect it all in 7 minutes? That will probably never happen and would be a very different looking data set nationally as a registry if it were that way. So yeah, no, it's like the balance between sensitivity and specificity, right? You try to increase sensitivity, you dock specificity, and so it's just a teeter-totter. Where's the best place where EMS has enough time to ensure the data is correct before before it's submitted. So yeah, I don't think one is more important than the other. It's how do we strike the balance where EMS feels comfortable that they're not pressured, but that they are not just sitting on records either.
Hey, Clay, is Mike Taylor, if I can make a comment.
Yeah, please.
So back 3 years ago when I was data manager for New York State and trying to build out the NEMSIS 3 data set for the entire state, that very question came up. And to me, it was always, it's not a cut and dried thing, it's a process. What I found in talking to EMS agencies is that, well, we don't want to send the state bad data, but we didn't want to send this, we don't want to send you the state bad data because you regulate us and we don't want you to totally know, how good, bad, or ugly we are. We want to make sure that our records are 100% before we send them to you, because we don't want you to suddenly come knocking on our door asking us, why this, and to find out that our data is bad. And the way I always approached that with the EMS agencies was, look, just send us the first record, and don't send us updated, just send us the first record, because that's the first blush that gets us in the system, okay? As long as you, the EMS agency, are doing a quality, are doing a good quality management program and reviewing your own pre-hospital care reports, you'll find these things later on, you will correct them for the next time, and the data will get better. We're not looking, we're looking for it to be a process, or I was anyway, back in that day. I'm looking for it to be a process and a process improvement, and not we got to have it all right all the time because Big Brother's looking. Just my thoughts.
Yeah, good thoughts, Michael. Really good.
And Clay, if I could expand on that as Mike's successor in that role, we've taken that point and we've taken it on the road to them as well. So it's not just something where we're sitting in, in bureau headquarters, although currently I'm sitting in my unit's headquarters at my residence, but where I'll be for quite some time. But we talked to them about, tell us what the problem is. Tell us if we've made the system so it doesn't work for you, but tell us how. And last fall we did a survey of our providers to ask them, exactly what their pain points were with the first setup that we did. As we had most of the state on 3.4 at that point, and now we're working on what will hopefully be our last revision to 3.4 to our documentation standard before we're happy to jump on the 3.5 bandwagon, and see where we go from there. But we've involved the providers in it and taken many educational opportunities, and my phone now rings off the wall, as I'm sure Mike's did as well, to bring people to the discussion points, and people get excited about talking about charting and data and where it goes and what they can do with it. I mean, once they got over complaining where I have 25 more fields to fill out, and once they got past that part, they said, and I started showing them things about what their data had been doing. They're like, this is awesome. We're not just, little squad out here in rural some odd county. We're actually having an impact on the state and the work that we're doing. Mike set the baseline for it. And, when he told me I was taking over the NEMSIS 3.4 transition, he said, go man, go. I haven't stopped yet.
Fantastic, Peter. Great comments. Todd, yes, please.
But just real quick, two thoughts. One is, I think the answer is both, and that's harder to manage and implement. But, our kind of approach, because we started with CAD data before EPCR was really much more than people dictating into a telephone down in Louisiana. And so that is always data that starts one way and changes over time. And so I think we were lucky in that we think of it as, what do we know at the beginning of the call, and then what do we know all the way at the end after the call's been QI'd and billed and things like that. And so I would kind of propose that in the long run, and there's a webinar right after this about the state of 911 data systems, and people are talking about doing something like NEMSIS in the CAD world. I've been on a couple of committees for that. So I propose that ultimately it's a spectrum and evolution, and if the system is built to take the data early, like Mike said, but also ready to be able to take the data at the end when it's clean, you really get the best of both worlds. It's again more underpinning and more work, but the benefit is kind of for everybody because I can know about things right away. But you do have that, big brother watching, issue that will come up because there will be some people that will be punitive about it, and make that feel bad. But best of both worlds is, to answer the fellow's question, is to get it, early and know that it's early. You don't think of it quite the same as data that is validated, and that would be my suggestion as we move forward.
Yeah, great, and that's a good point. And NEMSIS will allow for that, right? We'll overwrite an earlier record. So yeah, you're right. You could submit it early with missing fields, and then add those fields as they become available and resubmit, and it overwrites. Yeah, so there's mechanisms for that. Good comments, Todd. Any other comments?
I guess there was just a follow-up question to that from Benny asking, have you checked the amount of ePCRs that were updated after submission?
Oh, that's another great comment. No, we track that, but I have not. We have not looked at to see if that's different by state or over time. That's a really great question. Some states, I know of one state that allows EMS providers up to 6 weeks to submit records. Those are old regulations that sit on the books back to the days of paper forms and bubble forms. But that would be incredibly valuable to look at. Yeah, thank you for that comment. That's a great one. That's a great one.
And then there was just one other question from Karen Jacobson asking, can the details of the methods used be shared?
Sure. And actually the version of this, I'm happy to make this available, has some notes in the comment section. So if anybody would like a copy of this presentation, I'm happy. I have to PDF it, but I'm happy to just send you a PDF and there's comments about the methods in the notes sections. So yeah, happy to do that. Just send me an email. Yeah, thank you, Karen. Okay, great. Any other comments? All right, well, we're right at closing, just 2 minutes to close. I want to be sure I'm on time. Wow, thanks for the incredibly spirited conversation. This has been great. And wow, there's probably been 8 to 10 excellent research projects that have just been talked about just in the conversation. So incredibly valuable. We have some great stories to tell, ladies and gentlemen. Let's just continue to try to get better at it. And there's been some great examples of ways to improve it just shared today. So clearly we have a lot of good talent in this arena. Let's continue to make good use of the data and help our funders to recognize just how incredibly valuable pre-hospital care is. So with that, I'll close and thank you very much for attending. And please feel free to reach out if you'd like a copy of the presentation. Thank you, folks.